Hi, friends. Welcome to AOCPMR podcast. I am Meghan Mardashti, one of the AOCPMR's multimedia committee co-chairs and your host for today's episode. In this episode, we'll be chatting about long COVID in relation to physiatry. And to give you a bit of a rundown of what long COVID is, it's defined as the new or ongoing symptoms that starts after COVID-19 infection and can last for at least 3 months. Some of these symptoms can include fatigue, cognitive dysfunction, as well as even autoimmune dysfunctions. And to help us with the discussion today, we have an amazing guest, Dr. Audrie Chavez, who is the assistant professor in the Department of Physical Medicine and Rehab at the University of Texas Health Science Center in San Antonio, Texas. She is very passionate about patient and medical training education and is involved in neurorehabilitation, brain injury, as well as healthcare disparities research. Dr. Chavez, we are so grateful to have you here with us. How are you doing?
I'm good. Thank you for having me.
Of course, it is our pleasure. So, to kind of get us started, could you share a bit about your own journey and what brought you into the field of long COVID?
Yeah, so I did my I did my med school training at UT Southwestern, stayed there for residency also, and then it did a brain injury medicine fellowship at Spalding. After that, I'm originally from Brownsville, Texas, so my family and I moved into back to Texas, so we're in San Antonio now. So that's kind of how I ended up here. As far as long COVID, you will probably get a similar answer from many brain injury physiatrists, but there is quite a bit of overlap in some of the symptoms that we're seeing in long COVID, like autonomic dysfunction, some of the fatigue, things that can be similar to post-concussive syndrome. And so that's kind of how I got into this area. It was just one of the experiences and backgrounds that fit with some of the pathology that we're seeing in the long COVID patients.
Right, right. And with that, could you tell us a little bit more about, I guess, beside those symptoms, what are some other common symptoms that you do see with your patients with long COVID?
That's a great question. So there's a saying in brain injury, if you've seen one brain injury, you've seen one brain injury. And I would
Hmm.
say it's very similar with long COVID. So depending on the strain of the COVID virus, some of them affected more organ systems a little bit than more than others. And so depending on which strain they had, you can see variations of symptoms in every organ system. So I would say the most common symptoms are going to be fatigue, brain fog, some word finding difficulty, but from there, it ranges. So you'll have some
Sure.
people who have residual shortness of breath, issues with respiratory function. We can get patients who have GI dysfunction from some of those more GI focused variants, things that look a little bit like IBS. We also have patients who will have all sorts of weird neurologic issues like neuropathy type issues. We'll see people who have new numbness or tingling, polyneuropathy type pictures. So really anything and everything.
Gotcha. Yeah, I feel like it's a very, put it simply, bag of Skittles type presentation that it can be
Yes, for sure.
challenging to kind of get to. And with that, do you find that patients easily find their way to PM&R, or does it take multiple visits with different physicians for them to then eventually be guided toward PM&R?
I would say it is a little bit more difficult finding us. So I think in San Antonio, we've done a pretty good job with promoting the clinic and the clinic services. And so we are now getting so many patient referrals, new patient referrals from within the state, outside the state. And so and a lot of times it's actually from the patients themselves that have seen an ad on TV or on the news or heard about us somewhere through social media. So I would say we've done a pretty good job of advertising our clinic and the services now, but the timing of when we're seeing patients compared to when they first started experiencing symptoms is still delayed. So we are
Mhm.
seeing some patients that may have been dealing with these things for a year plus, and are just now making their way towards us. Because we're getting so many referrals, there's also a delay in when the patients are able to be scheduled. And so the time from the referral reaching us to them actually seeing us can be months at a time also. So I would say, it's probably getting better, at least in our location, but definitely noticing a delay in presentation where they've seen, um, been managed as best they could be by other providers until they make their way to us.
Right. I've had a very brief experience and encounter with a patient with long COVID, but I can imagine how frustrating that can be on the patient's end to have to go through all the different physicians and sometimes even either get misdiagnosed or not accurately diagnosed to then eventually be guided to PM&R. And let's say you have a patient for a long COVID referral in front of you. How do you um, I guess, approach to their evaluation, especially when their symptoms can be so multi-system and sometimes hard to quantify?
hmm The first thing I start with is really the definition. So, is this actually a long COVID diagnosis? So, what I start with is I figure out, when they had the positive COVID test, they don't need one, but if they have one, that's helpful.
Hmm.
Or when they started experiencing the COVID-like symptoms. And then we kind of figure out when their current symptoms that are still bothering them started. Did it start during the acute illness and or shortly after? And then has it persisted for at least 2 to 3 months? So you give a great example of the definition. And then also based on what their symptoms are, what kind of workup have they had so far? So if we have somebody who has palpitations, for example, have they had a cardiac workup? Has somebody screened them for any potential arrhythmias or anything else that might explain their symptoms, any other diagnosis? Because it is partially, it's pretty much a diagnosis of exclusion as well.
Hmm.
So those are kind of the initial things we're looking at. Do they meet the criteria for this diagnosis? And what symptoms are they still having now? And then also, what specialists have they seen so far and what workup's been done to date? So sometimes we have patients that may have not gotten a complete workup based on their symptoms for whatever reason. And so we will connect them to the appropriate specialist if there's still portions of their workup that needs to be done
Hmm.
depending on their symptoms. And then, we're lucky in our clinic because we are a multidisciplinary clinic. So we do also have a neurologist who is very passionate about seeing long COVID patients. So if we have a long COVID patient who has an incomplete neurologic workup or is having very pronounced neurologic symptoms, then we also have that connection so that we can see them together with the neurologist and then they can decide what medical management they might need. And then we also just recently added psychology, which is huge because, as you mentioned, a lot of these patients have dealt with this illness. They're not sure what it is, and maybe they're not taken seriously, or they're taken seriously, but they're just getting all these tests that are coming back normal, or maybe just slightly abnormal, but not quite meeting criteria for a diagnosis. So dealing with the chronic illness and the frustration that comes with, unrecognized chronic illness. Is also something that can take a huge toll on them. And so now we have psychology, especially for long COVID, focusing on some of the long COVID issues. And so that's very important to our piece as well.
Wonderful. That really warms my heart because the multi-system approach that you talked about is a very accurate way of how humanity is, or as how patients should be treated. It's very much so a mind, body, spirit, especially with chronic pain, especially with more of those, I guess, convoluted disease presentations like long COVID that it's hard to just point finger to, and that a lot of patients from, especially what you explained, sounds like they've been dealing with this, like let's say a year or so until finally someone's like, hey, what about this one thing? Or hey, let's go and get you referred to this clinic. And then from there at y'all's clinic, then maybe additional workups and such. Um, and that's been something I've been thinking about is how patients quantify pain because a lot of times that's very tough to explain. And um, there's also the very unfortunate other side that sometimes patients will get dismissed or not taken seriously. Um, so I'd be interested to hear how do you navigate those conversations with patients when they are frustrated, scared, or even possibly grieving those or their previous level of function.
Yeah, that's a great question. And I will say, the majority of our patients come in quite emotional and have gone through a lot of turmoil, navigating the system and trying to figure out what's going on. So it's just, what we train for, just being empathetic, listening, taking their complaints seriously, giving them a diagnosis if they need it can be powerful also just to have a name to what's going on, but also acknowledging that we have so many limitations still. So even though we can give a diagnosis, there is some hope in that we do have some treatment options that we can talk about too. And then also some therapy options, which works on trying to get them back as much function as we can, but also recognizing that there are some limitations to, what we're able to do. There's no cure exactly, but there are tools that we have that can help them with their symptoms and their function.
That's great. And definitely can serve as a good source of hope for patients to keep on going and continuing. And definitely would be interested to hear a bit more about the treatments and the therapy options that you mentioned.
Yeah, so for treatment options, there are some lifestyle things, there's supplements, and then there's medications that we have. And then, of course, we're PM&R, so we've got some therapies too that are focused for the long COVID patient. So when we're talking about lifestyle changes, the condition long COVID is driven by inflammation. So you got your initial virus, it creates this huge amount of inflammation. We used to think it was just the lungs, but now we know it can be any organ system in the body. And then long COVID is where that virus clears the body, but that state of inflammation sticks around. And so a lot of what we do management wise is we're trying to encourage a decrease of inflammation. And so the lifestyle things that we have, there's hydration. So making sure people are drinking plenty of water. We also, diet can be very inflammatory. And so a lot of our patients tend to do better on like the low histamine diet, for example, or the FODMAP diet, which is a diet used for irritable bowel syndrome. And then there's also stress, which can drive up inflammation. And so that can be a vicious circle for a lot of our patients, which is why we also have psychology services available. And then there is also aerobic exercise is huge for inflammation, but is probably one of the pieces that is the hardest for our patient population. So, long COVID patients, they tend to have issues where they are trying to do exercise or trying to do some sort of physical function. And then if they do too much too fast, they crash. And then it takes a couple days for them to come back from it. And so they're kind of stuck in this cycle where they're trying and they're trying, but they're just not able to get a good function without having this crash period. And so our therapies actually focus a lot on pacing strategies. So they're working on building back up endurance, but they're doing it in a way where they're pacing with the patients, they're helping them recognize their symptoms, know what they need to do when they're getting close to a crash. And then overall goal is to improve endurance, reduce the crashes, but also help them with recovery when they're getting to that point as well. So we have a couple of different groups in our area that have really worked towards understanding what sorts of therapies are most helpful for our patients. And so those groups are also part of our team and do really well with getting them back to some level of normalcy for them or new normal.
Mhm. Yeah, that's that's pretty great. I haven't or I didn't know much about the crash period, but it makes sense. And um I feel like with the inflammatory diet, just, living the day to day in the US, there is a lot of inflammatory, I can assume, like with fast food or some of the processed foods that do add more, I guess, inflammation to our diet and to our body can be challenging to remove or adjust for some of the patients because that we're kind of tapping into the habit building and really starting from ground up with working on sleep, diet, and exercise. And that can be challenging and sometimes like harder for some patients to attain because as we know, unfortunately, healthier diets are costlier diets, and kind of keeping that other side into consideration that not all patients might have access to all resources or to be able to afford healthier diets. Um, and you also mentioned medication, so I'd be interested to
Mhm.
hear what are some of those medications that you have used.
Yeah, so for medication, so some patients, like a more natural approach to things. And
Right.
so sometimes we may start with supplements. So there's not a ton of high level research yet into the supplements that are helpful, but there are some small case studies. And then there's been research into the supplements in some other inflammatory driven conditions. And so some of the supplements that can be helpful is turmeric, anti-inflammatory, and then also if patients are having joint-related pains, it can be helpful for that as well. There's also vitamin C works as an anti-inflammatory as well as a immune system booster, and so that's another one that we tell patients might be helpful. And then one of the newer ones, which actually does have a pretty large scale trial completed, is N-acetylcysteine or NAC. Not a new supplement recommendation, one that we've used in concussions before and for similar symptoms, brain fog, fatigue. And so they did a trial at Yale looking at the use of this supplement and found that in long COVID, it also helps with brain fog and fatigue. So that's also another recommendation that has even a little bit higher level evidence too, that we can recommend to patients. And then when we're thinking about the medication part, because some people, you'd be surprised how much research and self-advocacy a lot of these patients are doing because they've been dealing with these things for so long. And so some of them may have already tried that route. And then the kind of the next step too, if they're open to trying medications besides, supplements, then the next level would be doing a histamine blockade. So we use an allergy medicine like loratadine, or we can also try Allegra or Zyrtec. And so we pair up a histamine 1 blocker with a histamine 2 blocker. We have them take those scheduled. So even if they're not having allergies or acid reflux, we emphasize this is for the purpose of inflammation and the long COVID symptoms. And then we'll have them try that for about 2 months. And then we can see, touch base again, see where they're at with their symptoms. So that's another medication option we have, and also lower risk. So it's available over the counter. There's minimal side effects. And then if that doesn't work, then some people have already tried that as well when they get to our clinic. So we kind of meet them where they're at and what their preference is. But one of the other medications that we have now is low dose naltrexone. So naltrexone is a partial opioid. The way we use it is it's compounded into a much smaller dose. So we'll start the dose at 1.5 milligrams. So it does have to go to a specialty pharmacy where it can be compounded. We don't know the mechanism, but there's an anti-inflammatory portion to it. And then, of course, we know the pain mechanism on the opioid receptors. And so this has been shown to be helpful in people with brain fog, fatigue, sleep issues. Can also be helpful for patients who are having some of those polyneuropathy, painful type sensations, or people who are still having residual joint pains as well.
Mhm. I really appreciated that step-by-step approach, and especially taking into consideration the supplement aspect of it. I'm a huge fan of turmeric, being Middle Eastern myself, where we use turmeric in a lot of our dishes, but also that it does actually block COX-2 for that inflammation pathway, which and has a pretty similar mechanism to ibuprofen. So that just brought a smile to my face when I heard turmeric and then vitamin C. And that's really interesting about N-acetylcysteine. I think I've heard about creatine and some studies being done with more of like brain recovery and utilizing for brain injury patients. But also, I guess now it's become a more trendy supplement for muscle recovery and dietary purposes. But that's really cool about NAC. And you mentioned that there
This
was like
list of
large.
supplements, yeah, and this list of supplements is definitely not all inclusive. There's so many,
Right.
and sometimes even, patients are coming and asking me about some that I may not even be familiar with that are, just different cocktails and things like that.
Hmm.
So, depending on their symptoms, people with GI symptoms, we may recommend pre and probiotics, because the gut flora is also super important. And
Right.
then, we also there's been newer things looking at peptides and nattokinase and things like that, but there's just
Wow.
some of these just don't have as much research into it in the long COVID population. So,
Hmm.
supplements can be a little tricky just because, we're not there's not a ton of studies and FDA management that goes into it. So we try to just, give recommendations as best we can based on the person. Um,
Right.
of course, there's always risks and benefits that come with trying any of the supplements. And so just, sometimes they'll just ask for guidance on some of those.
Right. But it's always great that there are so many options and kind of like this, again, step-by-step approach of like, we're going to cover our bases but with therapies, lifestyle modifications, but also here are some other options that we have. And it's a very, very holistic approach to kind of calming the nervous system. But also, I guess, yeah, it's more so pretty much calming the nervous system and taking away some of that in big inflammation in the body through different approaches. Um, and I'd be interested to hear, from your experience working with long COVID patients, what it has taught you about, being a physician that you may have not fully, I guess, appreciated earlier in your career.
That's a great question. I would say I mean, probably more than one thing, but one of the things that has been really, people always say you're going to be a lifelong learner and you
Right.
understand, but this takes it to a whole new level. There are things about long COVID that we're learning, on the week to week basis. And so really trying to stay on top of that when I also like have my, you know, first passion with TBI and staying on top of that. So that's been challenging, trying to balance keeping up with all of the latest studies and things like that, because your patients are definitely trying to stay up to date as well and want and have questions and want guidance on some of the things that they're reading also. And so it really emphasizes the point of lifelong learner because there are just so many things we don't know and that we're still learning at a very rapid pace. And then also in PM&R, we deal with chronic conditions, right? We are dealing with things and learn. And this one is similar, but a little bit more challenging in that, it's a difficult because we don't know really what the trajectory looks like. And so there's research into it. We've got our own, we're part of the Recover study. And so we don't know. I have some people who get 100% better after trying some of these things. I have some people who have no change at all. And then I have most people get better to some degree, but are not 100% back to where they were before. I have no way of knowing like who falls in what trajectory. I don't
Mhm.
know. I can say, just based on my clinical experience, about 5% get totally back to normal, about 5% stay the same. And then, like I said, most people fall in that other in between category. But also just dealing with not having a full understanding of a disease process
Right.
and what that, recovery trajectory looks like. It can
Hmm.
also be challenging, but is also a little bit similar to brain injury in that regard. So,
Right. And I feel like that's definitely an advice like I've gotten in the past that's be comfortable with the uncomfortable, which can sound a little bit vague, but a lot of times I think in medicine we don't have those definitive answers or exact trajectories that sometimes also patients want to know. And we can look at the what available data we have, which I believe in the case of long COVID, it's not a lot, and we're learning as the field is progressing. And like you said, learning clinically with our patients, but also that lifelong learner mindset is a lot more amplified in this field as well. Um, and as we're, coming a little bit or toward the end of our episode, we usually like to end it with a reflective question for our guests. So, would love to hear any piece of advice that you like to leave our listeners with.
so I will say that it is important as whether you go into a specialty or subspecialty, or our general PM&R, I think having that foundational knowledge of just general PM&R things is so important. In the TBI realm, I still deal with people who have like post TBI or post stroke shoulder pain. And so I'm still putting my MSK brain to work in some of those situations. And in long COVID, like we discussed, every organ system, and I kind of bring my own unique TBI management skills to the long COVID clinic. So if I need a neurostimulant, I may consider neurostimulants in some people. If there's neuropathic pain, we're getting neuropathic pain medicines. So just recognizing the value of every aspect of PM&R, because those general skills really come into play no matter what subspecialty you go into, and obviously are super important if you're general PM&R, but are also still remain important if you do a subspecialty.
Mhm. Beautiful advice. Definitely is important to know all of our bases, be comfortable with the bread and butter of physiatry. Because I think sometimes it's very easy to get caught in the what's next cycle, but also just be very hyper focused on the one area that you very much so enjoy. But like you said, you never know when you might need those basic skills that you've learned or the topics that you've learned in residency to make sure that you can tap into and that you're comfortable with. Well, Dr. Chavez, thank you so much. This was a wonderful conversation. I know I learned a lot about long COVID, and I hope the same for all of our listeners. And hope that all of you wonderful listeners found the episode just as helpful as I did. And if you guys have a few seconds, it would be amazing if you can please leave a review on our Spotify podcast page and let us know what you'd like to learn about in the future. Thank you so much all for tuning in, and thank you so much, Dr. Chavez, for your time and being here with us. Until next time.